Like I said, this is the McClain Labs webinar. All things pathology questions. Any questions that you have, type them into the Q&A or the chat. Sarah and I are moderating all of that. So at the end, we're going to play a short presentation first on onychomycosis, and then at the end, we'll be answering all of those questions live. So be thinking of your questions, jot them down, go ahead and type them into the Q&A if you'd like, and we'll make sure that we take as much time as needed to get all the questions answered. So while we're getting started, I'm going to go ahead and share my screen here. And I want to show you the McClain Labs virtual booth. Sarah, you can see this?
We can see it.
Okay. All right. So like I said before, go to podiatrymeetings.com, check out all the virtual sponsors there. But McClain Labs booth is really awesome. You can hover around and get all kinds of different resources here on their booth page. You can register to win a derm light and get a free caliper. They've got all kinds of helpful videos down here. So just take some time to look around there if you have any questions. Their contact information is there and all of that. All right, so we are privileged to have Dr. McClain and his team here doing this sponsored webinar for us. We've started a sponsored webinar series, and so this is one in that series. Dr. Steve McClain is from High Ridge, Missouri. He received his BS from Missouri State and graduated from the University of Missouri Medical School. He's board certified in dermatopathology, and he practices dermatopathology in Smithtown, New York, and is the founder of McClain Labs, which is in Smithtown, New York. Dr. McClain's an adjunct professor of dermatology and emergency medicine at SUNY Stony Brook, and he's a frequent lecturer at local and national meetings and a proud sponsor of many podiatric conferences. Tonight, Dr. McClain's going to present on onychomycosis, diagnosis and treatment, and he'll be answering all your questions live following the presentation. So if you have any questions during the presentation or after, simply type them into your Q&A or the chat box, and we'll discuss all of them after the presentation. So thank you again to Dr. McClain and his team for taking the time to join us, and we hope that everyone watching learns a little something new. And with that, we will begin.
Okay. You know, in medical school, I would fall asleep the first lecture after lunch almost every afternoon. I hope the same does not fall to you. I'm a dermatopathologist, MD, and I wanted to stress to you that we are all one. In terms of these diseases, no one group has the market or the lion's share of these. We are all physicians, whether DO, DPM, MD, we're all physicians. And we practice one medicine, all one. I changed the title, I'm sorry, Scientific Diagnosis and Treatment. I thought I better throw something in about treatment. I do have an academic appointment at the University at Stony Brook in dermatology and also in emergency medicine. The latter mostly relates to wound healing research. Well, the diagnosis is pretty obvious most of the time. What I've discovered is that the lab diagnosis is not so simple. To the podiatrist, you look at these nails, this debridement, and it's pretty obvious. And I actually invented a test for this, and sometimes it's helpful to segment out a test. And this particular test is called the cheese test. If it looks like stinky cheese, it's fungal until proven otherwise. And in my opinion, may as well lay it out there, nail dystrophy is not a pathologic diagnosis. It's a myth. It's a false negative lab test. I'll tell you how I got there. Does this look cheesy to you? This is a section of nail. Let's see, do we have a pointer here? section of nail, and there's a little faint touch of eosin on top, and the blue is the Alcian blue on the bottom. You can see it's irregular. But most of the center is dominated by this plastic-like material, or cheese. This nail's been soaked in 10% to 20% KOH for an hour, and it's still relatively impermeable. You wonder why the antifungals don't go through. There's this big plastic component in the center, and it's why these nails are so hard. They're abnormally hard because of highly cross-linked fungal polymers. I know you're not hearing that from anyone else, but it's what I believe to be true. So we would call this cheese test positive in our lab. I'm going to start off talking a little bit about onychomycosis treatment. And the first stage or step in the treatment is to make the diagnosis. And as residents, once you make the diagnosis, don't deviate from it until you have positive evidence to the contrary. The treatment then, it begins with something like debulking the nail or avulsing the nail. And the dermatologists routinely use 40% urea to knock all that cheese stuff down, and then they'll treat with terfenadine. Suppressing fungal sex in the nail bed. Women patients are frequently bothered by the notion of fungal sex in the nail bed. I don't know why, but they really are bothered by that. And it's what's happening. It's the infection foments in the nail bed, way down low. And we need to treat the base until normal, which may take a year, may take a year and a half until that nail grows out. The goal then is to achieve normal nail transparency, translucency, a thin nail. And the normal nail is much thinner than you might think. I actually measured more than 1,000 of them within the past 2 years, and I'll present the data. And it should cut easily. Combine treatments whenever possible. You have to gang up on the fungus. The fungus evolutionarily is much older than we are. These infections have been around far longer than medical science gives it credit for. Whether you treat them systemically, topicals. Here's an example, Vicks Vapor Rub. I know it's in the lay literature and so on, but part of the reason it works is it has 3 antifungals. These are all plant oils, camphor, eucalyptus, and menthol. Combination therapy. Enhancing penetration of topicals. I'm going to spend a couple minutes on because there are some new developments in enhancing the penetration of topicals. Heat. If you travel to Hong Kong or any tropical country, in the closets they have heaters. They raise the temperature of their closets to keep the fungal growth down. So some of our old-time therapies, whether it be diathermy or hydrotherapy that involved heat, suppress fungal growth. And it's still the principle by which laser and ultrasound work. Same thing for photodynamic therapy or the blue light therapy. You put in delta amino levulinic acid, ALA. Whether you're treating a solar keratosis or a foot fungus, you paint this on and shine a blue light on it. Okay? This is photoactivated inside the cells and it kills them. It works for solar keratosis, an early form of squamous cell carcinoma, and also for fungus. Okay. The diffusion enhancers for transungual delivery. I think this is a new and kind of fun development. This was just published last month, cycloperox delivery into the human nail plate using novel lipid diffusion enhancers. They tested this in horses' hooves at the University of California at San Francisco, where Howard Maibach has been there for about 40 years. I'll point out that Mark Sellner here is a podiatrist, and these two, Sellner and Rosenthal, actually own a company. I'm not going to mention them by name. But they received a patent on their product. And so that's about all I'm going to say about treatment. The first step, though, is to make the diagnosis. One can understand why these don't penetrate very well, because in the middle, There is a cheesy yellow plastic material, highly cross-linked polymer, that's of fungal origin. Okay? It's not a nail anymore. It's a fungal pseudo-nail. Okay. The field of surgical pathology was invented by a surgeon, Bill Roth. Okay. Many of the advances in ulcer care, nail care, and so on have been made by combining the efforts of surgeons and pathologists. But Bill Roth was his own surgeon. And you can still bill for a KOH test in the office even today. Eosin is a pretty good stain for fungus. I didn't know that until a couple of years ago, but it stains the cheesy part. That same yellow part is pretty well stained by eosin. PAS is a good stain for carbohydrate. It's actually a chemical reaction. It stains specifically carbohydrate, and so the red is all carbohydrate. And this may have been taught to you as being plasma. It's not. These are little fungal breeding grounds right here. These are vertical columns, and around them, each one of them, grow the hyphae. But the PAS by itself has a sensitivity that's about 50%. If you combine the PAS by adding an Alcium blue stain, the sensitivity goes up to more than 90%. And so anything that's red or purple or blue is fungal with the combination stain. Alcium blue is known as a mucin stain, and so the underside of the nail, the deeper portion, stains preferentially with it. If we look at Aspergillus niger in a culture, I don't know if you can see that, but you see this faint little rim around here, this little shining light. That's a mucus layer that's down at the base. Now, if we look at this in a tissue section, the fungus naturally layers out in culture. That's what fungi do when they grow. And the same thing happens in the nail bed infections. At the base, this blue part here is from the Alcium blue, and you can see it's riddled with hyphae. If we zoom in on it, I thought those were just hyphae and some bubbles, but if you look at these, you notice that there's some cross. These are septate immature hyphae, but they're only staining with Alcium blue. Okay, so the immature hyphae will stain with Alcium blue and not with PAS. Notice that the PAS is being laid down almost like on top of the railroad tracks. In the center is the Alcium blue positive part, and the carbohydrate is laid down on top of it. And that's what fungi do in culture. That's part of what they do. Part of the reason we're as good as we are today has to do with this Cuban-born dermatologist from Miami, Nardo Zeiss. He still practices, and he wrote this paper in the Archives of Dermatology in 1972, and he described the discoloration, the presence of tinea pedis, the onychomycosis or splitting, and that the nail was thick. And we know now it's mainly nail bed that's due to the thickening. But in this same paper, and this is a time when, this is pre-Lamisil, when surgical excision for onychomycosis was done. Can you imagine that, taking off the entire nail unit surgically? Here's the proximal nail fold, matrix, nail bed, hyponychium, and the nail plate. Notice the nail plate here. Most of this thickness is not due to the nail plate, but this accumulation of nail bed cornified cells. So most of the infection, and in fact, if we look at the nail bed, here's the normal epidermis. The nail bed is hyperplastic, and this dark line above it is part of the disease. So it's an accumulation. The infection is centered in the nail bed, and so the treatment has to not only take care of this mass of fungus on top, but also the infection in the nail bed epithelium. This is a great paper. Richard Shear, former president of the American Academy of Dermatology. There's Warren Joseph, Brian Markinson, Dr. Armstrong, Roderick Hay. Some really high-level people wrote a paper on diagnosis and definition of cure. I'm going to stick to the diagnosis because I can be critical about this paper a little bit. Primary criteria is discoloration, yellow, white, orange, brown. Secondary criteria, tinea pedis, they listed it down here, but onychomycosis. Here's the main problems I have are in these two parts, and we'll go over those. And the lab is relatively insensitive. That's one of the big problems and one of the reasons why I say nail dystrophy is a myth. The false negatives are so high in both cultures and by either KOH exam or by H&E and PAS histopathology that we let you down, frankly. The lab is letting you down, or used to. Cheese test positive, anyone? It's yellow, it's white, it's brown, it's orange. The thing I would point out to you is that I didn't appreciate that you can do a little bit of quantification on this. How much of this nail is infected? Approximately. Anyone? 90? Okay. I'll say 100. That's fine. Nearly all of it. The nail matrix in general is not involved, but it may be. But the absence of involvement proximally is what gives us hope about treating these, that we can clear these. This is tinea-pedis, a common accompaniment. And when the skin comes off in sheets like this, it's pretty much diagnostic. And if you zoom in, you can actually see some large hyphae forms here. I think so. Just as you can see them on the wall of the bottles in which we culture them. Onychomycosis is very powerful, splitting of the nails. Within all these splits, there are fungi. There's one here, there's some here, there's here. And it's the fungal materials in there are splitting apart the nail. The split actually begins down below because these proliferate in the nail bed squamous part, and then they'll blossom. So a whole group of fungi will bloom at the same time, and it's PAS positive. And you might see it a little bit here. This is where the Alcian blue really helps out, or the combination of the PAS plus the Alcian blue. And in this case, there's even some melanin pigment. Well, what's my gripe about the table here? Well, first off, it's ungual, not subungual. The second is that it's a nail bed infection. The lab, as I said, is a 50-50 proposition, or used to be. And this word debris, how many times have you seen the word debris in a medical paper? What does debris mean? We'd have been better off calling it cheese. Okay? At least that would be more descriptive than just debris. Was this debris after a hurricane? Debris on the side of the road? Debris. And my last complaint is that they didn't define, what was normal. What is the normal thickness of the toenail? Does anyone know? Well, I'll tell you. So updating this, we agree with the discoloration. Tinea-pedis is a very powerful independent criterion. Onychomycosis, powerful. What we disagree about is what is the nature of this debris. So I'm going to give you my description here that it resembles cheese. It's more like plastic biochemically. It's a fungal polymer that cross-links. It's infectious, and it's a mass. It doesn't go away readily. Okay? So if you treat the nail bed and clear it, but leave this fungal biomass, it can reinfect the nail bed. It is a nail bed infection, not a nail plate, as was listed in this paper. And the normal toenails measure less than a millimeter, more like less than 0.8 millimeters. And what we can add to the lab is that by adding a PAS to the Alcian blue to the PAS stain, more than 90% of the nails that you submit to me are now positive. So instead of a 50-50, now it's 9-1, or maybe 99-1. Cheese test, positive or negative? I hear a positive. Okay. You say, well, that's a goofy way to saying it, Steve. And it is a little bit goofy, but making an observation and scoring is an important a tool that one can use. This is not a nail. Here's the nail plate, and it's discolored, but notice most of the accumulation is here. Or look at this one. You've got a little bit of nail plate. Look at all the nail bed cornified cells here. If we look at these in section, this is the nail plate up here. This is nail bed down to here, but it's all red. Okay, eosin is a pretty decent stain of fungal products, not necessarily of the hyphae themselves, but of the fungal acid products that are in the nail. Okay. Here's something that's new, and I bet you don't know this, because I didn't know this myself until a few years ago, but the squamous nail bed epithelium is infected and it needs treatment. In fact, that's the site of action for Lamisil. It accumulates in these cells. You say, well, where's the hyphae? There aren't any hyphae here. But notice this nucleus here. The normal nucleus should look something like this. This nucleus is pushed off to the side by this red inclusion. And some of the inclusions actually have vacuoles in them. Here's another one here. Whoops, sorry about that. Here's one that almost looks like a protrusion into the nucleus. So it's the nail bed squamous epithelium all the way down at the base needs treatment. So if you're trying to get topicals down to there, you've got to get them into the nail bed epithelium. Okay. Here's another one that doesn't exactly look the same, except here's one of these where the nucleus is kind of cupped around this inclusion. And you've got these kind of strange streak-like things. But notice all these, notice all these blue staining, these are hematoxylin staining, intracellular forms. Okay, those aren't normal. Okay, so the infected squamous epithelium needs treatment. We're going to go through a few cheese nails for a while and see if you agree or disagree. This is the undersurface of the nail, and so note this little mound here, but the whole thing is fungal. It's 100% fungal from top to bottom, from beginning to end. And where that heaped up area in the center, you can see it's PAS and Alcium blue. In fact, there's so much Alcium blue you can't even hardly see the PAS. But there are some PAS positive forms, and note this kind of line here, very common in these nails. You flip it over and look on the other side, and it kind of resembles a clam shell or an oyster shell or something. These parallel wavy lines, little onycholysis here, some splitting. Pretty common appearance, actually. Anyone? Cheese or not cheese? This one we can't see so well, but there's almost a leaf-like configuration. If you see something in a nail that looks like a plant, you're probably right. Dermatophyte. Cheese test positive. Some of these almost just, more than cheese, you just say yuck when you see it. So, oh my God, what is that? Here's the low power, the eosin. So I haven't shown you too many hyphae yet, but the eosin is, when you see when in one of my reports, the red from the eosin, that's an abnormal nail that's staining. It's an accumulation of eosin staining components. Not necessarily the hyphae, but a fungal product. This one is kind of fun. This is the undersurface of a nail, and you notice there's a little bit of orange here. But look on the other side, you've got a split nail. When you see somebody that has what looks like the most god-awful nail paint, in fact, I call it that, the awful nail paint sign. If it looks like, brown, they're covering something up. The only reason for putting on that ugly of a nail polish is to cover up something that's even uglier underneath. And you'll see that when you go back in the clinic, you'll think of me and you'll say, oh yeah, that nail polish is so ugly, there's got to be fungus under there, and you'll be right. This does not project especially well, but let's go to the next one, maybe a little bit better. You see these thread-like. Sometimes with treatment, the nails initially look worse. As you clear up some of the easy fungus, now these thread-like, root-like structures that are coming out of this part become more apparent. And then you have to warn your patients that their nails may actually look worse 2 weeks later, but they will get better. So what is the thickness of the normal toenail? We'll go through these. So write down, you've got a piece of paper, write down your 5 nails, 1, 2, 3, 4, 5. I don't know if you can see that. I can't see these, so we can't have you score them. But the podiatrist who did this scored this one as positive and all the others negative. This is kind of a misshapen nail. You can't really see these in this projector, I'm sorry to say. But by the PAS scoring, positive, 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 positive. In general, when you see one nail that's positive, you can count on 3 or 4 of the other ones being positive as well. They're just more subtly involved. Another way of looking at it, same nails. Now we measured the thickness, so the thickness was 1.1, 0.8, 0.5, 1.0. These black ones are all positive as well. The only normal looking nail, the only normal nail by thickness, by PAS, and by clinical exam was this third one. Okay. So we made a men's and women's, and it turns out men's toenails are different than women's toenails slightly by thickness. Men's toenails, the hallux, 1, 2, 3, 4, 5 on the right. Men's are thicker than women's. The purple is the overlap between men's and women's, and the pink is the women's side. And in women's, the 5th toenail is often as thick or thicker than the 1st toenail. Distinctive profile in women and men. So they differ by gender and by toe. So the thickest is 1. In women, the 5th toe was as thick as the 1st toe. Okay. And the thickness is about 0.5 millimeter, plus or minus 0.2 millimeters. We sampled 1,200 toenails to get that data. It was rejected by the JAD, but maybe with your help we can recruit more patients. Some of the nails you look at, I mean, it's just the yuck test. It doesn't even look like cheese. It's brown. You say yuck. And that just immediate revulsion is a sign that there's something growing in here. Inside that pigmented nail, you'll find these chitin structures. You notice a tube here and here. Fungal chitin, it's like it polymerizes and cross-links so much it's tough like an insect shell. And in fact, it refracts polarized light. It resembles glass. It's so tough. Okay. Melanin you can find in these. This is a little too zoomed in. But sometimes it's obvious from the structure of the melanin that there's fungus growing in there. Dematiaceous fungus. So in our lab, the criteria is when we see a cheese test positive, then we're going to keep staining until we find at least 3 PAS positive or 3 Alcium blue positive hyphae. And so the combination of the blue and the red is useful. When you see them together and they're glommed onto each other, you can be pretty sure that that structure is fungal, even if you don't necessarily recognize it as a hyphae, because these fungi have a number of different forms that I did not know until a few years ago. Okay. This is a fetal toenail, week 17, and this is the 3rd toe. And I want to use this to point out, embryologically, the nail matrix comes right down onto the distal phalanx, and this is an immature bone forming. This is the periosteum around here. But notice this collagenous structure that ties into the sulcus here and ties into the proximal matrix. So a thick nail has pretty close access. Doesn't take much trauma to get down here. And this is at week 17, so it's a pretty thin nail. But the same principle holds true for adults. These same structures are there. Okay, how many cheese nails here? Anyone? 1, 2, 3, 4. Every single one of them. Tinea pretty common. Well, what happens when you start debriding this and it bleeds? We've found several cases like this where some of them go on to ulcerate when untreated, and with treatment did not ulcerate. We don't know whether they would have ulcerated or not, but this to me is a sign of impending gangrene of the 3rd toe. When you get down and it starts bleeding, that needs to be treated. Okay, summary. The infection foments in the nail bed. All 10 nails need to be treated. In fact, when I give out an antifungal, I tell them to treat all 20 nails, because usually it's pretty common to have 1 hand and 2 feet, right? Your dominant foot from picking your toe fungus. It's a serious infection in diabetes, and I would urge you to think about, as you enter your practice lives, when you see diabetics with toe fungus, that you need to think about treating them. need to do more than think about it. I think you do need to treat them. To me, onychomycosis is difficult to detect, and so what happens is that in the old days, my rate, I had about 50% nail dystrophy and about 50% toe fungus. As my methods have improved, I now see nail dystrophy as a diagnostic myth. It's a false negative lab test. If we do enough stains, if we do enough cultures, you'll find the fungus. If anyone of you wants to participate in the normal nail study, we're trying to finish it by the end of the year. Photograph, score them, and clip each nail. Submit them in 10 separate nail bags to my attention. In closing, toe fungus is not the most important part of my work. Wound healing is. My interest, what led me to podiatric podiatry, podiatric pathology was wound healing. My interest in wound healing. We've been studying wound healing at Stony Brook for a long time. You say, well, here's a day 28. This is an animal study. And here's a diabetic wound. It started out 6 millimeter punch biopsy that went right through to fat. And it's healed completely in 28 days. The glucose was 600 at this time. You say, well, that's pretty good. Until you look at the normal. The normal measures about 0.9 millimeters. This measured 2.7 millimeters across. And notice the thickness of the scar. And notice this one is blue, bluer than this one. It's about 50% more blue, in fact. There's about 50% more collagen. This is a trichrome stain, and in a trichrome stain, collagen stains blue. These tend to have gaping wounds, and when they heal, the amount of granulation tissue in here is usually thin. So these are thin, gaping wounds. There's not much tensile strength in these. Okay. The normals end up with a thicker, stronger scar, has more collagen in it. Okay. So in closing, while my main interest may be wound healing, the toe fungus, what is not known about toe fungus is surprising. Many of these, I think one of the mistakes that podiatrists make is in not biopsying enough. If you're getting too many false negatives from your lab, there are some things you can do about it. You can submit more nail samples. If it's a 50-50 and you submit all 10 nails, then one would guess that in real toe fungus, about 4 or 5 of them should be positive. So just submitting more sample would help. I look forward to talking to you in the future about work in diabetic foot ulcers, because I think that is where the podiatrist can have a real difference. Dermatologists are not doing much work in this field. Surgeons are not doing much work in this field. Where the podiatrists have an avenue or an opening is in scientifically tackling these foot ulcers and improving your care. When you have a niche that no one else can even come close to your treatment, the patients will flock to you. Thank you for your time.
All right, so we're going to answer some questions here. We're just getting all of our smart people back on. All right. Okay, so we've got Dr. McClain and Carol McClain and Kim, all from McClain Labs, joining us here. So we're going to start with some of these questions that rolled in. If you have any kind of pathology question, anything that's on your mind, too big, too small, whatever, put it in either the chat or the Q&A section, and we'll be reading those off to get those answered.
If you don't know where the chat is, click where it says participants, because that can be kind of tricky to find sometimes. So at the bottom of your screen, where if you hover over your screen, some basically buttons where you can have all your tools, participants will open.
They blocked me.
Nope.
To start, I keep starting it. It's not doing anything.
There we go. There you are.
There we go. So when you find yourself under participants, or actually when you go to the tools underneath there, you'll see chat, Q&A. So you can use those buttons down there at the bottom of your screen. Just make sure you have to hover over it.
You want me to
No,
do
the
that?
attendees.
Oh, okay.
You're
All right,
good.
so
You're in good shape.
we're watching these questions roll in. So I'm going to start off with the first one. Do we need to anesthetize the toe prior to obtaining a PAS?
Well, it's a good question. In the short answer is we do the PAS in our laboratory. So you just send in a nail in formalin or in a dry nail bag. We can do it in general. We can do it from a clipping, although the more sensitive part is the more proximal you go, the more sensitive the test will be. If you're going to affect the nail fold, or you're going to avulse the nail or do a punch biopsy of the nail, then you're going to need to anesthetize. Am I using a pointer?
Okay, so the next question is from Dr. Bogus, and I'm sorry if I pronounce your name wrong, I'm bad at this. Are you using a pointer? Is that related to the presentation, or is that something having to do with pathology?
I think what he's referring to was the lecture. This was a lecture from quite a while ago, and you can't even see me in the lecture, but no pointers were available, so sorry. Feel these. There's a interesting question from one of the common questions is, can we identify or can we speciate nails? And the answer is yes. I think we can do that morphologically to a pretty good degree. When we do that, the subject of mixed infections comes up, because it's not infrequent that you have a dermatophyte like trichophyton plus a mold like aspergillus, and sometimes you may also have one or the other of those with candida, yeasts of candida. So that mixed infections, mixed fungal infections are really common. The bacterial components are also there's also a bacterial component, and in some of those the bacteria may predominate, and so you end up with things like Pseudomonas, or you end up with a mixed fungal and a bacterial infection. I hope that answers your question. I answered that live.
Okay. All right. So the next question is: dremeling a fungal nail and breathing in the ungual hyperkeratosis a way to get a fungal lung infection, or is this a myth?
Well, it's not a myth. The bigger risk is not from breathing in the fungi into the lungs, but rather a chronic pulmonary disease in which it's partly allergic. So breathing in the fungus and cornified cells dust may induce a pneumonitis, an eosinophilic pneumonitis. And I have seen 3 New York podiatrists. Now, these were all gentlemen pushing 80 who developed this, and all told me they extensively used a Dremel. So some kind of protection needs to be worn, and some kind of exhaust system. I personally don't think it's a great idea, because you can use a manual curette if that's what you'd like. Anyway, I'm not big on Dremel personally. It's your office, your life. You do what you want.
All right, so Dr. Andre, who was, by the way, the winner of our $900 shopping spree, she asked, how does the laser treat nail fungus? Is there a difference between red light and blue light?
Wasn't it Kmart that had the blue light specials? There was a Kmart store that had blue light specials. I'm not an expert in laser. I have been studying it for about 10 years. I confess, I don't exactly know how laser works. However, there was a paper just published, I think, November 2019, which showed 85% of the papers, so this was one of those meta-analysis, 85% of the papers that studied it showed a beneficial effect. I don't exactly know. I'm sorry to say. To pasteurize something, you have to get it to 90 degrees centigrade for 1 second, or for lesser temperatures for longer time periods. Whether heat will slow the growth of fungus, and excessive heat. I'm a personal believer that you have to use multiple therapies, or you have better success with multiple therapies. So I'll leave that short. I don't know how lasers work, but people who are willing to spend money on and were willing to put in the effort to work on their toes can get improvement.
Okay. So right now we've answered all the questions that have been presented so far. So we still have lots of attendees watching us live. So if you have any questions, go ahead and type them into Q&A or the chat. Or if you'd like, you can raise your hand as an attendee and we can call on you and you can ask the question live, bringing out the homeschool mom and me with the call on you language. But while we're waiting, I just wanted to remind you guys to make sure you check out the virtual booth for McClain Labs on podiatrymeetings.com. They're giving away a derm light and a free caliper just for visiting. Do you guys want to talk to us a little bit about your lab specifically and, how you got started and what you have to offer?
Dr. McClain, you can always tell the Eddie Van Halen story. That usually wakes people up.
I'm already intrigued.
I don't think anybody's gone to sleep yet, but maybe.
Okay, just
we are approaching 8 o'clock on the Eastern time period.
Question came through, but I want to hear this.
A new question popped up.
Yes.
From Dr. Nadal. How accurate is KOH by itself in diagnosing toe fungus? It's really accurate. How accurate are you at diagnosing bread mold or cracker mold or something growing? We know what fungus looks like, and the pattern, as I showed you in some of the tinea cases, it's a repeating pattern. So if you see it, those branching patterns as they go down, as they get in closer, they look like more fungal. KOH, it's accurate. It's not very sensitive though, because you've got to scrape the nail. The trick. Okay, there's a trick in every lab technique that I know of. The trick with the KOH is you have to put a drop of KOH on the slide, and then you put it on a warming surface. It used to be we just put it on the light bulb or on the back, and you work it for about 5 seconds, 10 seconds. And that chemical action will dissolve the cornified cells. And when they part, it's like seeing tree branches on your ground after a storm, after a windstorm. They're pretty obvious. You can say, are there branches there? Yeah, there are branches there. And the KOH is kind of the same test. So if you do it right and you warm it properly, they open right up. But fungal disease, sometimes the people with the worst disease have the fewest fungi. Sometimes the thickest toenails have the fewest fungi. That entire upper level may be all plastic, and you don't see any hyphae until you get right down to the bottom. So I don't know if you can see that. As I'm looking at this, I realized my hand was too low. So I'm sorry about that. What is your combination of, should we consider treating any severity? That's an interesting question, Doc. Is it Dr. Dye? I assume it's Dr. Dye. What is your, well, the thick, we also mark not only the types of fungi in our reports, but also give an indication of whether it's ingrown, which I think needs some special treatment, and whether it's gryphotic. Is it too thick? And mine is a practical definition, but is it too thick to be penetrated with a topical? And so whether it's 3 or 4 times normal thickness, when the nail gets more than 2 millimeters thick, most topicals are not going to penetrate. It just, the fungal material, there's so much of it that it just doesn't penetrate. There's been cool devices tried, these little drill devices that they sell in Britain and have been used. Those are kind of cool. A severe nail may need avulsion and then topical treatment, especially with molds. The mold onychomycosis, the data are limited. However, from the data I know, that when there's a mold present, you should really think about complete avulsion of the nail and topicals, plus pulsing with an oral once a month. Imagine that, avulse or complete debridement, topicals plus an oral. Another avenue, to work them into a regimen where they see you as part of the helper in the team, so that if you laser them, develop the most successful guys and women. I don't mean to imply gender. The most successful physicians treating this get results when they bring them back for a repeated laser program, some kind of topical treatment, and pulsing them with an oral. Everybody's got their tricks. I understand that. But what I'm saying is that if you compare it to dentistry, this is how I understand it. Maybe it's not quite right, but most people get religious about flossing about 2 weeks or a month before they go see the dentist. So if you want them to do your regimen of multiple, bring them back more frequently. Bring them back every month. Bring them back every 3 weeks. So you get them on a regimen where they start the medication, they do the pulsing of the oral, and they're into the regimen, because these regimens take a year. You have to build up enough medicine in there, and when you pulse them, and you have to let the nail grow out completely. And until the nail grows out completely, the fungi can grow down as well as up. So if they're in that nail and you haven't debrided it, they can grow right back down again.
All right. While we're waiting for other questions to come in, I thought this maybe would just be potentially helpful for everyone that's listening. So in terms of samples that come in, I imagine that some are really strong samples and some maybe are weaker samples. What can podiatrists do in terms of their technique to, I guess, kind of encourage a stronger result in terms of the test?
Well, the simple answer, as I gave before, is send more sample. So multiple nails. Send the more proximal. One of the issues with the mixture of fungi is that many times my concept is, and this is based on multiple nails over time, but my concept is that patients with onychomycosis your fungal nails can get moldy. So on top of what started out as a just straight onychomycosis, you now get a second mold growing. So that's one of the issues. Now, I'm sorry, I think I lost my train of thought in there somewhere, but you want to repeat that question?
Yeah, it was just, what are your tips for regarding the technique in taking a biopsy or sending samples so that the outcome of the result is the most accurate?
Well, the second part is to go proximally. If you clip more, then clip, put that in, because the more proximal part of the nail has more fungi. So that would be the second part. There's a third reason for biopsying the nail, and that would be if you're looking at a pigmented streak. And for there, the question is melanoma or nevus. And there, the biopsy needs to be done far, far proximally. You need to get into the matrix. Okay. Now, someone just asked a question: how do you pulse dosing, and what medication do you use? There's two basic. Now, everybody's got their regimen, and if you've got a regimen that works, stick with it. I'll support you in that. But for terbinafine, it's a pulsing of 1 week out of a month for out to 6-9 months. So you're taking the same amount in 9 months. You take about the same amount of medication as if you did it for 12 weeks. So if you do it, you could actually go out to 12 months. And so you would take it 1 week out of the month, for example. In the case of diflucan or difluconazole, it's about 200 milligrams, either one pill once a week or one pill twice a week. So very low dose, and that you would take every week. From some podiatrists I've spoken with, no labs on the difluconazole, and we're able to keep them on it for months. So those are the orals. Now, with terbinafine, obviously you've got to do at least at the beginning, and at some point in the middle, and at some point towards the end, or if there's any problems, you need to do liver testing.
How often, Dr. Eisenberg just asked, how often during treatment do you need to do lab tests?
Whenever, if they've got an issue, or they think they have an issue, um, do the test. You do it at the beginning. You need to document that they didn't start out with liver disease. Then I would repeat it at 3 months. And once again at the end. But if there's any issues, any health issues, it's not a great drug for people who are on liver dependent drugs like Coumadin or warfarin. And the other negative is, I think, that are the statins. Most people are reluctant about putting statins and terbinafine at the same time. So those are the two, not that those are necessarily contraindications, but I think you're going to find some resistance from most people on those.
Okay, what do we have? How many weeks should the patient stay on
Difluconazole? Again, they can stay on that at that low dose, one pill. In fact, if they're getting response, you can drop out the second pill and just make it one pill towards the tail end to stretch out your therapy, because you want to have the nail grow out. It's oftentimes that last little bit at the very tip. I don't know if you can see this, but the last little bit where you still have this persistent hyperkeratosis. And in those, you may have to go back to a topical urea. You may have to, finishing that last little bit, whether it's with laser, repeated debridement, multiple antifungals, sometimes combining things like cyclopirox, terbinafine, putting them together with a compounding pharmacy is another option. Sorry.
Let's see. Andosa would like to answer this question. Would avulsion of the black nodule be okay for biopsy?
Okay, good question.
Can we read the entire question, just because the attendees can't see the question? So I just want to make sure they hear the entire question.
Okay.
We're the only ones who can see it.
So there's the question is about a black longitudinal band or streak in the toenail. And the question, I think, is, would avulsion of the black longitudinal band be okay for biopsy? Yes. I think that, I don't know if Mike can, well, there's probably a couple of ways to answer the question, but number one, the black band may be due to benign lesions like nevi, or malignant lesions like melanoma, or they may be due to a pigmented fungus growing in there. And we don't always know which. And in fact, that's another whole hour's lecture. But the things that would make you want to biopsy. So the question is, one, if you see that and you avulse the nail and it's black underneath on the nail bedside, that's a biopsy. If there's Hutchinson's sign, pigmentation of the proximal nail fold, pay attention. If more than a third of the nail is involved, meaning a broad streak or one that's growing, the patient tells you that it's growing, it's getting larger, that's worth paying attention to. And in those instances, you have a couple of choices. You can avulse the nail, but you must biopsy proximally. The reason for that is that melanoma begins in the nail matrix, not the nail bed, but the nail matrix. So avulsing the nail, if you do that, it can either make it easier for you to do your punch, or you can take your scalpel and do a shave biopsy and shave off. And sometimes when you do that, the nail matrix will reconstitute itself and there's no split nail. Okay. So there's two choices. Either you use a very narrow punch biopsy, 2 millimeter, or you can do a shave biopsy after the avulsion. Now, a third technique, if you don't want to avulse the nail, and you can do this, but again, you must obviously numb the patient up. You biopsy right in the proximal nail fold. You biopsy right through it with a 2 millimeter punch. Because even in the thick nails, you can usually go right through it with a 2 millimeter punch. And you biopsy all the way down to bone. Now there's one trick, and that is, if you're going to do it, you should use one of those punches with a plunger. Okay, if you squeeze those melanocytes, you can mess it up. So I will warn you, I would get one, hold out until you get one with a plunger, or do a shave biopsy after avulsing the nail. Okay, what I answered. Oh, the questions went away, so I guess
Yeah, it
we're
looks
okay.
like we've answered all the ones that have popped up. We are at the hour mark. I don't want to cut anybody off, but I know it is getting late. And so I guess we could wrap it up, though. If there's anything that either Kim, you want to say, or Carol, you want to say, or Dr. McClain, whatever you'd like to summarize tonight's lecture and Q&A with, or if there's anything specific you want to discuss about the lab, now's the time to do so.
And don't forget to mention how great we are.
Obviously, that is, yes, that would be most helpful.
Well, I would just like to say thank you for attending to everyone tonight. And just a reminder that we do all dermatopathology. We do gout, we do melanoma, we do bone biopsy. So if you have questions after tonight, feel free to call us. Call McClain Labs at any time. Dr. McClain is always available. There's any questions you need to help your patients, we're here to help you. Dr. McClain is an academic dermatopathologist. We're here to help the patients, and we're here to help you. So thank you for attending, and I'm very grateful to Ann and Sarah for pulling together these meetings, especially during these virtual crazy times. And I want to wish everybody a happy Passover, happy Easter, happy spring, happy everything. Thank you.
Happy opening day.
Yay, let's go Mets! Woo! Thank you to everyone.
Okay.
Don't forget to enter the raffle. You want to enter the raffle, go to podiatry.com.
So yeah, that was our last kind of reminder. Don't forget to visit podiatrymeetings.com, head to the virtual booth section, and go to McClain Labs booth. And already told you guys, you'll be able to go through their entire booth, look at their collateral, ask more questions. There's a specific question form. And if you answer a question, you will be entered to win a dermatoscope or a caliper. There's more lectures on the page. And then there's also a reminder. So always check in on that page as well to see Dr. McClain's schedule for free CME webinars with Present eLearning. So that's a huge benefit for online credits. So thanks again, everybody. And did you have anything else you wanted to wrap with?
No, thank you as always for paying attention to what we're doing. And thank you to our sponsors for donating their time and putting on this informative lecture. Hopefully everyone took something away, and just looking forward to more in the future. So that's it.
Good night, everybody.
Okay.
Okay.
Good night.
Bye.
Thank you.